Hello, welcome everyone. My name is Adam Kaufman. I'm a board member at the CMTRF. I've been here since 2019. I'm also a patient. This session in this room will be, what is CMT? I had the pleasure yesterday of listening to Mary Reilly's keynote speech. She's a leading mind in CMT. She's a professor of neurology at University College of London, Department of Neuromuscular Diseases. She's a leading mind in CMT and the person you basically want to hear this talk from. Thank you, Mary.
Thank you very much, and it's very nice to have been invited to be here. So my remit, I was told to keep this very simple, so to start at the beginning and work up. So if people know a lot more about what I'm saying, please forgive it in that. Okay. Is that moving forward? Okay, these are my disclosures. So you've heard already the CMT, it actually stands for Charcot-Marie-Tooth, so 3 people. And actually, there was years when people thought, is that the right term? But it's easy to say CMT. And that's the reason we call it. It's just easier to say. The medical term is hereditary motor and sensory neuropathy, which actually tells us what it is in more detail. And I'm going to dissect out that term. So the first thing is, this is a neuropathy. So in terms of a neuropathy, if you look at a body, you've got the brain and spinal cord, which is the central nervous system, and you've got the nerves in the arms and legs, which is the peripheral nervous system. And when there's a problem with the peripheral nervous system, it's called a neuropathy. So when we're talking about CMT, we're talking about it being a neuropathy. Now, what is motor and sensory? Well, if you look at a picture of the body again and you look at the spinal cord, so what you have here is a motor nerve going from the spinal cord down to the muscle. So imagine it going down to your foot, and a sensory nerve. So if you touched something, the message going up again. So we've both motor and sensory nerves. And classic CMT is a motor and sensory neuropathy. And if you look at these nerves in more detail, if you look at the motor nerve coming down here to the muscle and the sensory nerve, and if you look at a kind of a cartoon of this, you'll see within the nerve there are all these small fascicles. Now, this is a picture of a normal person's nerve. Now, you might say, how have we got that? Well, my predecessor, so I took over from P.K. Thomas, a very famous neurologist in Queen's Square, and there was another famous neurologist called Richard Hughes and another one in the US. They all gave their nerves. So part of becoming a neurologist those days was to give up, have a nerve biopsy of a normal nerve. Let me tell you, that's not something you want to do if you have no damage to your nerve. So these are normal nerves. But as you will see, you begin to see in the nerves, there are these round bits which are axons and myelin. And if you look at it in higher magnification, you're beginning to see this in more detail. And at the highest magnification, this is what we're talking about. Here we have a nerve, and inside here is the axon, and it's surrounded by myelin. So the size of the message that is conducted in nerves is determined by the quality and the health of the axon, and the speed of the message is determined by the myelin. So from now on, we'll always think of nerves as the axon and the myelin. But as you can imagine, they're interdependent. If your axon dies, the myelin will die eventually. And if your myelin dies, the axon dies eventually. So even though we think of them as separate, they're completely interrelated and need to be both healthy for normal nerves to work. So when we talk about neuropathies, we think about them. Do they start in the myelin, and then we call them demyelinating? Or do they start in the axon, and we call them axonal? But remember that eventually, both sides are affected. So when I see some patients in clinic that have severe CMT, when I do the electrical studies, they're inexcitable. So I cannot tell where it started because the axons are very damaged. But that basic of demyelinating and axonal is the basis of CMT. Now, if we go back to the original definition of what does hereditary mean? Now, I know you all know what it means, but what does it mean in some detail? So if we think of what we are, we're made up of a code called DNA. And DNA is made up of these amino acids. You can see them here, adenine, thymine, guanine, and cytosine. So these tiny amino acids. And these together, each one of these is what's called a nucleotide. And each one of us have 6 billion nucleotides. And the reason we are different is because we've major numbers of variations. So on average, we've 3 to 4 million variants each. So when you go to your doctor to find out why you have CMT, they have to work out which of those 3 to 4 million is causing your disease. And which of them are just giving you curly hair versus straight hair versus, a loud voice versus a quiet voice. That's what makes us different. And these codes for DNA are packaged into what are called genes. And the genes are packaged into chromosomes. And we've 46 chromosomes, 22 pairs, one of each from a mother and father. And then if you're a woman, you have 2 X's. And if you're a man, you have an X and a Y. Now, all our DNA is in the nucleus of the cell. But we also have these, what we call batteries in the cell called mitochondria, and that's a higher view of it. Now, these mitochondria, you've heard a lot about them yesterday, are really important batteries in every cell in our body. And they're really unusual because they have their own DNA. But you only inherit your mitochondria from your mother. Now, that's very rarely associated with CMT. So I'm just saying it so you've heard of it. So mitochondrial DNA is separate, and it's how we trace evolution. Because the one thing everyone is sure of, but everyone knows a mother carries a child, so you know it is the mother. Sometimes the father may not be as obvious, but the mother is always the mother. So that's how evolution is done, by tracing the mother's genes. So if we go back to the genes, so each one of these genes, they're packaged in these chromosomes. And a gene codes for a protein. So the protein that gives you brown eyes or gives you blue eyes, that will have a genetic code that tells you what color your eyes are. And a simple way of looking to the code is here, it's called DNA, and it's double-stranded. And how does it make a protein? When it gets broken down, it's called transcribed into RNA and then translated into a protein. So every code eventually codes for a protein, and our bodies are made up of millions and millions of proteins. And as I said, we have these chromosomes, the 22 sets of chromosomes. And in CMT, almost every chromosome has some genes on it that cause CMT. Not everyone, but almost. And here you have chromosome 17, I'm hoping showing the right one, which contains the PMP22 gene, which causes CMT1A. Now, the story started with Charcot-Marie-Tooth in 1886. And then the first genetic discovery was 1991. And I recall that I had just moved from Ireland to England to start research, and I recall the absolute huge excitement. It's hard to tell you how exciting it was for the first gene in CMT to be found. Massively exciting. And because it is the commonest, a lot of people got an answer quickly, and that's unusual. Often when you find a gene, it's really rare, and a few people benefit, but this is amazing. And we now have over 130 causative genes. I never give an accurate number now because it changes overnight. So we have lots of genes. So what does inheritance mean? Well, you can inherit it in multiple different ways. And the commonest way, it is autosomal dominant inheritance. So for every gene, and you'll see 2 genes here, you'll get 1 copy from your mum and 1 copy from your dad. There is no way around that. That's just what it is. So for autosomal dominant, you only need 1 copy of the abnormal gene to have the disease. So this person has the disease because they have 1 normal gene and 1 abnormal, and their partner has 2 normal genes. So when they had children, they obviously had to get one or the other of these genes. So whether they were male or female, they had a 50% chance of inheriting the gene. And that's called autosomal dominant inheritance. In autosomal recessive inheritance, you need 2 copies of the abnormal gene to have the disease. If you have 1 copy, you're a carrier, but normal. And every one of us in this room carries 5 or 6 copies of abnormal genes that potentially could cause a disease, but we don't have children or with the other to get the other one. So cystic fibrosis, Friedreich's ataxia, they're commoner causes of this. So in this scenario, the parents are carriers. There was a 1 in 4 chance they would inherit both copies of the normal gene, a 2 in 4 chance that the children are carriers, and there's a 1 in 4 chance that someone would have the disease. Now, it doesn't mean that if you have 16 children, 4 will have the disease. It means each child, there's a 1 in 4 chance. But in this disease, you need 2 copies of the abnormal gene to get the disease. Now, X-linked, and I'm only going to talk about X-linked dominant. So this form of the disease is where the gene is carried on the X chromosome. And a woman has two X's and a man has one X and one Y. Okay? And we won't say which is better or worse. We're just different. So if a male carries the X thing, remember for him to have sons, they have to inherit his Y chromosome. So all male children of a male with CMT-X will be normal because they'll inherit the unaffected Y chromosome. Whereas all the girls that a man has who has X-linked CMT will inherit the X gene to be his daughter. So when a man has X-linked CMT, all his sons are unaffected, all his daughters inherit the gene. Whereas if a woman has it, because she has one normal X and one abnormal, there's a 1 in 2 chance either her daughters or her sons will inherit the gene. Now, because men have only one X, if they have the abnormal gene on that X, they're more severely affected because they don't have a good X to make up for it. Now, women have two X's, but very early in utero, in the first few weeks that we are developing, we inactivate randomly in every cell of our future bodies one or the other X. So if we inactivate all of the abnormal gene, we can be normal. If we inactivate all of the normal gene, you can be as severely affected as men, but most people are in between. So most women with X-linked CMT are more mildly affected, and some people have no symptoms. I have yet to meet a woman that I can't find something abnormal, but they may have no symptoms, but they also may be more severely affected. And it's about a 5 to 10% chance they're as severely affected as a man, a 5 to 10% chance that they've zero symptoms, and most people are somewhere in the middle. So that's what that means. So that is what hereditary motor and sensory neuropathy means. Now, the next thing is, how is it classified? And I have to say, we've done a disservice to the community with this. It is a bit of a mess. And we've argued about this for years, such that we've given up arguing about it because it's just not worth it. So the simple way, and I tend to be simple, is think back to demyelinating and axonal. And demyelinating is called CMT1 and axonal CMT2. And that's the simplest way of thinking about it. And that's determined by, remember what I said about the speed of conduction. So you do a test on one of the nerves in the upper limb and you work out what the speed of conduction is. And if it's below 38 meters per second, it's called demyelinating, and above it's called axonal. But sometimes in an individual, their nerves can be different, or in a family, and that's called intermediate. And often with X-linked CMT, the family looks intermediate. The women look more, they're faster conduction, and the men have slower conduction. And in certain genes, we see this intermediate. So when we're in clinic, we work out what the electrical studies are. We practically never do nerve biopsies now because we don't need them. We used to do them, but it's extremely rare now, unless there's a diagnostic uncertainty that it is CMT. So people often get a nerve biopsy to see if it's something else that there's a treatment for. And we can usually in clinic work out the inheritance, although I have to say in the UK, the families are smaller and smaller. So often you have 1 or 2 children and the family is too small to work out the inheritance. So you're not always sure, or you may be the first person in your family, because sometimes it is de novo. The gene starts in you with nobody in your family having it before you, but your children will have the same risk as if you had inherited yourself. And it has got more complicated. And so CMT1 is now considered if it's autosomal dominant. And if it's demyelinating, CMT1, it's actually called CMT4. And I blame the US about this. They wouldn't give up on this. We wanted in Europe it all to be CMT1, but they won half the battle. The half of the battle they didn't win is with CMT2, all dominant and recessive is the same. But that's confusing for patients. So if you have CMT1, it's autosomal dominant CMT1. If you have CMT4, it's autosomal recessive demyelinating. But if you have CMT2, it can be dominant or recessive. Then we have X-linked. Then we have some people who are told they have hereditary motor neuropathy because it's pure motor, or hereditary sensory neuropathy because it's pure sensory. But we know that the genes that cause these, both dominant and recessive, overlap. So when I talk about CMT, we mean the whole family of conditions. All the ones that are pure motor, pure sensory, and classical motor and sensory. Now, what are the letters? So the letters are added to tell you the gene. So CMT1A, it's the PMP22 gene. CMT1B, it's the myelin protein 0 gene. CMT4A is the GDAP. Mitofussion is CMT2A. So we add a letter on. So CMT1A, CMT1C, etc. The problem is this. As the years go on and we find more and more genes, we're now into the second letters of the alphabet. So we have CC, GG, HH. Now that makes it absolutely impossible to remember and actually very confusing for patients. So I've made my life simple. I've given up completely on this. I think of it, is it one or two, and what's the gene? So I talk about MP0 CMT, mitofussion CMT, PMP22 CMT. And the reason I think we're moving towards that is we now know 77% of the causative genes. This is a paper from my group last year. We have almost 1,700 patients, and we find the gene in 77% of patients who come into the clinic. So we're very quickly moving towards a stage where everyone will know what gene they have. And we're much better at CMT1. We know 97% of the causative genes, but with the axonal form of CMT2, it is about 50%. And there's something odd that's making it difficult for us for all of those. Now, finally, to go on to what are the symptoms? So we've talked about motor and sensory nerves. So first of all, most forms of CMT are called length dependent. Now, what that means is the longest nerve in your body is to your feet. So if you're a 6-foot man, it's about a 3-foot nerve. It's a lot of work to do to give a message from your spinal cord to your foot. So symptoms often start in the feet and slowly progress. By the time they get to the knees, you get hand involvement. That's what we mean by length dependent. Now, not every form of CMT is length dependent. Some will be hands first, but this is the commonest, and that's what it looks like. And many of you will recognize this. You're more wasted below the knee than above the knee, and you begin to get wasting in the hands. That's what typical CMT looks like. So what are the symptoms of motor involvement? So first of all, when there's damage of the nerve supply to the muscle wastes. So the muscles become thin and they develop weakness. Now, weak, wasted muscles cramp more easily. I have, someone that comes into my clinic and I'm examining them. If they don't cramp when I'm examining them, it's unusual. Not that I'm cruel, but because you get them to resist a movement, it looks cool. You can get muscle aches, and patients often will have a discussion and we'll say, does it feel like you've run a marathon when you've walked 15 minutes to come to my clinic? So it's that feeling of fatigue in the muscles. And there's fatigue because of all of this. Because it can start early in life when you're still growing, you can get severe foot deformity, particularly with CMT1A, and you can get deformity of your spine and contractures. And of course, the classic problem is to get difficulty with walking. This hopefully will work. And this is the classic, what we call foot drop. You've weakness more distally, so when you walk, you have what's called foot drop. And many of you will recognize this gait from CMT. And we can now measure that by looking at the amount of fat in your muscles, because when your muscles don't work because the nerve supply is not working to the muscles, you accumulate fat. And what this looks like is this. So this is someone with very mild CMT with only 1.1% fat. This is someone with slightly more severe CMT with 5%. And this is a woman with severe CMT who has 87% fat or 81%. And this always makes me think you have to treat early. You don't want your muscles looking like that. You've got to treat to prevent that fat, and fat accumulates in muscles. And this for us is a very good way of being able to measure disease in people, but it also lets us see. So if we look at it, the feet are worse than the calves are worse than the thigh, and we measure the percentage as we work up. Now, foot deformity. This is particularly severe in CMT1A because you have unequal weakness. You're weaker with your ankle coming up and out, and it's stronger turning in. And I'm grateful to one of my patients that sent me this picture recently of her grandmother. Now, this is someone that lived a long time ago, and this would not happen now in some parts of the world, but it will happen in others. So if you get severe foot deformity, that's what will happen. And that person would have to walk on the outside of their foot, and that's not possible. So that's why even with CMT1A, you do meet people who have had an amputation. Because if that's a fixed foot deformity, that rarely happens now. But pes cavus, clawed toes, callosities are very, very common. And, you can get hand involvement. It can be severe, and sometimes and very occasionally it's wrist involvement. And as I said, you can get, actually, I wanted to show this. It's an old poster that the CMT UK, the UK CMT used to use. And I used to like this because it just reminded me all the time. It's all about your feet and walking. It's not that it's all about it, but that's the first symptom for everyone. I found it a very grounding photograph. But you can get deformity of your back. Again, this is commoner in certain kinds, kyphoscoliosis, particularly if you have weakness when you're still growing. Now, what about the sensory nerves? And I think the sensory nerves are just as important. So, classically, you have reduced feeling and numbness. And often, as a doctor, you suspect CMT because the patient says, I feel normally. And then you examine them and they don't feel normally at all because it creeps up on you and therefore it's normal for you. So we can only say it's normal if we're comparing it against something. With certain times, you can get tingling, pins and needles, burning, and with certain subtypes, neuropathic pain can be quite severe. And I would say with 1B and X1, you see more pain of neuropathic type than some types. And if you don't look after your feet, you get complications. So you get cuts that you don't feel, ulcers, and you can get infection of the bone, osteomyelitis. And you can get with certain kinds, again, 4C or 1B, periaxin as well, what we call sensory ataxia. So if I put my hand out, it's nice and still. And if I close my eyes, it's nice and still. Sensory ataxia is when I close my eyes, it does this because I don't know where I am in space. That's why some people will say the minute it's dark, they're much worse. It's called sensory ataxia. And this is the kind of problems with sensory. You can just have ulcers. And if you have lack of sensation, you can have repeated injuries to your ankle, giving you what's called Charcot joints. It's because you've repeatedly injured it. And of course, you can get ulcers and eventually need amputation. Now, this is rare, but I'm showing these not to in any way make people, ooh, that doesn't look good. It's to tell you how important sensation is. So I've told my patients repeatedly, you need to look at your feet every night going to bed to make sure you haven't done anything. You never walk on sand in the heat, unless you're in England when it's never that hot. You can't wear flip-flops most of the time. You don't put your feet up against the heater. You don't use a hot water bottle. So there's certain simple things that are very important in foot care. And what about other things? And people ask about these. What about breathing? Well, you do have peripheral nerves that go to your diaphragm. And in severe forms of CMT, you can have breathing difficulties. And in certain subtypes, like 2C, you can have vocal cord and breathing. And overall, sleep apnea is more common, even in CMT1A. So it is something we screen for in clinic. We ask the questions every time someone visits. Now, I actually always show this diagram because your face is part of your peripheral nervous system. So you have nerves that go to your face, and it's a bit like a hand, the nerves to the face, for feeling and for movement. So in certain forms of CMT, the more severe forms, your facial nerves can be involved, and in certain rare forms, they can be involved. Certain forms can give swallowing difficulties and hearing problems. Vision is very rare because the nerve for vision is actually not a peripheral nerve. But just when people sometimes talk about the face and people describe symptoms, in rare forms, you can see it. And there's a huge number of genes that cause CMT, both type 1 and type 2. And even within that, we see huge diversity. So we see the length dependent, but certain forms start in the hands. And this is a patient who's a very severe insensitivity to pain, which has a much more severe type. So we know that individual types are different. And I would say with 3 billion nucleotides, 3 to 4 million variants, every human is unique. We know that. And therefore, every CMT patient is unique. So you may have the same underlying genetic abnormality as the person sitting beside you, but they will be the same as you genetically otherwise. So every patient is completely unique. It doesn't mean we have to don't develop common therapies, but everyone's experience of it will be unique, and it is really important we remember that. Now, management, we will be talking a lot more about that in different sessions, but for the most patients, what's really important is to get a diagnosis. And I don't think you can underestimate how powerful it is to know the type you have. For those people who don't have a diagnosis, I find it amazing how relieved people are to know what type it is. That can allow them to understand the inheritance in their family. Many patients come to me when they've had children, or they don't really worry till they want to have children. That's really important. Clearly, physiotherapy, occupational therapy, orthotics, bracing, surgery, when and how. We heard earlier today about surgery, and my top patient has 17 operations and it's CMT1A. So that's the top diagnosis. So, should someone have 17 operations? And you're absolutely right. The surgeon will say you'll be in and out 6 weeks. It's 3 to 6 months. So it is a huge amount of your life. And it's during the teenage years and the early 20s. Really difficult time. Pain, very important to work out what is the cause of the pain. Is it muscle? Is it nerve? What is the cause of your pain? Fatigue management, Pacing, pacing, pacing. If you do a huge day, pace yourself. Pregnancy management. This was brought up by someone yesterday. How does your body cope with getting that big? And I often found the problem is after they've delivered. The body suddenly, not that you get pregnant slowly, but you deliver quickly, the body is suddenly completely unstable. And of course, I hope the last bit will be, we'll have CMT specific therapies pretty soon. I just thought I'd finish with this. So this is a small study we did in the UK some years ago, 2016. So the UK, once you have a therapy and once it's approved, it then has to get accepted for kind of national reimbursement. We have a different system, the NHS. And what's really important is what they perceive how severe the disease is. So we looked at this and, I was surprised. The mean age of retirement in our CMT population was 46 years. And that often it's not that they wanted to retire, but they couldn't do the job. In London, most of the underground does not have disability access. It's a really old underground. Most of it does not have lifts yet. I mean, that just means you can't get to work. So that's very important. 81% of people that retire, it's either completely or partly due to their CMT. And a huge number of patients said they're not doing the job they wanted to, or they've had to. I had one patient in clinic yesterday who said, I have to apply for a job that's lower paid to be able to do the job because it's office-based. And 12% of CMT patients had retired before 35. And this was only looking at patients who are working. Now, obviously, many patients have a normal, fulfilling working life. But this is a serious condition. And I think just because it's not a condition that in most patients, is fatal, or you look at, motor neuron disease and you look at SMA, and these are extremely serious conditions. I would not underestimate the seriousness of CMT, the morbidity associated with it, the day-to-day difficulties with living with the disease. So I hope I've given you a very simple explanation of what CMT is. And this is my group in Queen Square. This is our hereditary neuropathy group and our funders. And thank you very much. Happy to take any questions. And over there.
I just want to make sure I got this. It's clear. Did you say that if a mother has CMT, she cannot pass it on to her son?
No.
No. If the father has CMT.
If the father has X-linked CMT, that would be CMT-X1, the GGAB1 mutation. Yeah. He cannot pass that on to his son because to have a son, he has to give the son the Y chromosome.
So under what circumstance can the father pass it on to his son? All the other forms of CMT, okay. Autosomal dominant CMT. It's just that one. Because my husband has it and my son has it.
Yeah, then it won't be one of those. So CMT-X is the second commonest form of CMT. It accounts for about 13%. Yes. So that's just for that particular type. Most forms of CMT, it's equal. Male or female can get it 50-50 chance. Now, some forms of CMT, there is one form, a rare form of CMT1. Carrying the gene doesn't mean you'll get the symptoms at the same time in the family. It can vary. And there's one form of CMT where you can have a severe person and someone with no symptoms, but they both carry the gene. Okay. So having the gene doesn't mean it'll always be the same, how that comes out in a person.
Okay. Thank you.
Okay.
Yes, hi, my name is Linda, and I'm just curious. I have CMT1A, and as my brother does as well, and he has severe pain in his legs, and he has for years. I've never had pain in my legs or feet or arms at all. How rare is it to not have any pain when you have 1A?
Yeah, so that's a really interesting question. So traditionally, people used to teach that you didn't get nerve pain with 1A. You do, but it's rarer than some of the other types. But pain itself is very common. Usually joint, muscles, or muscle aching. So it is, in my experience, relatively rare for someone to say they've never had pain or don't have any pain, but we do see it occasionally. And there can be variation within a family. So if I see someone with very severe nerve pain with CMT1A, I always check them to make sure there's nothing else going on. So I check their vitamins, I check for diabetes, I just make sure there's nothing else going on. But you do see it in some people, and we don't understand why some people get pain and some people don't. Because sensory nerves for feeling can give pain, if they're, they can give pain when they're damaged, they can give pain when they're getting better if you treat them for other things. They're just very volatile.
Thank you very much.
We have time for one more. Oh,
yeah, over here.
do this one, Rob. Thanks.
I have a few questions, but maybe I'll try and wrap them up into one. Is there any advice for people with CMT in terms of physical activity, or when to use orthosis or insoles or braces? Would you have any recommendations for that?
So it's very hard to give a general recommendation, but there's one thing for sure. So years ago, people said that if you exercised, it wasn't good for you. That is completely untrue and has been proven in multiple. So keeping yourself as fit as you can, that doesn't mean, like if you're someone that doesn't have CMT and you're just falling apart with pain running, you stop. So it's the same advice. If something hurts, you stop. But you've loads of good muscles. So keeping yourself as healthy as you can is important. People with CMT on average have higher BMIs. They're more overweight than the normal population because they don't get the same options to exercise. So I would say exercise is very important, but the particular exercise, I hate to hear any of my patients doing treadmill. I had a 17-year-old boy in clinic recently, and he was doing gymnastics, and he had CMTX, and he kept spraining his ankles, and we had a chat. And then he came back next year and he took up breakdancing. He thought that was going to be better than gymnastics. So it's finding the right exercise, I think. Bracing orthotics is a hugely personal thing. Most people, if they have weakness to a certain extent, particularly more than a certain grade, benefit from it if they're the right bracing at the right time and if they're acceptable. If they're brilliant, but they look terrible and you don't want to wear them, you will not wear them. So I think that's a very individual. And you've all probably been through, people that need bracing, been through, lots of different types that will suit you and won't suit you. And someone says it's brilliant and you say, but it hurts me, it's causing things. So I think it varies, but it can improve quality of life hugely in the right bracing for the right people. Sometimes people only use it when they're exercising. They don't use it all the time. And I think it's interesting. One of the other studies we did is people with CMT fall more in the house than outside the house, because outside the house, they're careful. They'll use the stick, they'll use the bracing, or they're just careful. In the house, take off everything, wander around in your feet, put on slippers without backs, wander around in your socks. That's when people fall. So it's a matter of an awareness.
True.
Thank you.
Thank you, Mary.